The following podcast is part of a certified educational activity titled Precision Matters in Non-Small Cell Lung Cancer. Everything you need to know about biomarker testing and targeted therapies. Access the entire activity and complete the post-test at peerview.com/ZEV860. Downloadable slides and practice aids are also available.
So welcome everyone to the Precision Matters in Non-Small Cell Lung Cancer. This is a PeerView Live event. Everything you need to know about biomarker testing and targeted therapies. I'm Dr. Joshua Sabari. I'm a thoracic medical oncologist at NYU Langone Health Perlmutter Cancer Center. And I want to turn it to my colleagues to introduce themselves.
Hi everyone, I'm Zosha Piotrowska, thoracic medical oncologist at Massachusetts General Hospital in Boston.
Hello everybody, Gilberto Lopes. I'm a medical oncologist in Miami at the Sylvester Comprehensive Cancer Center.
Hello, my name is Jonathan Goldman. I'm at UCLA where I focus on thoracic oncology and phase 1 drug development.
Welcome everyone, and thank you for being with us tonight, and thank you to the attendees for being with us. We have a packed agenda. I want to introduce our partners. So first and foremost, LUNGevity. Thank you for partnering with us on this event. Also want to thank the Oncology Brothers, Dr. Rohit Gosain and Dr. Rahul Gosain, who will be with us this evening discussing cases that are important in community practice. I also want to thank our sponsors listed here. So what are our goals for today? We want to augment your knowledge of biomarker testing. We want to focus on targeted therapies. And boy, it's been an exciting space over the last 5 to 10 years. We want to equip you with strategies for developing individualized treatment plans for patients with non-small cell lung cancer with actionable, targetable alterations. So in today's educational sessions, we're going to address the meeting need, the growing need for biomarker testing in non-small cell lung cancer. We also want to focus on how we can match actionable alterations with optimized targeted therapies to improve outcomes for patients with lung cancer. So this is dizzying, right? If you look at this slide and thinking about how many therapeutic options are available, how many mutations are now actionable in lung cancer, it's impressive. And I think it's a growing field, a growing space, and it's a space where our patients now have a lot of hope and a lot of opportunity. And we're excited tonight to actually tackle a lot of these mutations, a lot of these therapies that are now available to our patients. So what are the guidelines? What are the guidelines for biomarker testing? So we know any patient diagnosed with the stage 4 lung cancer needs broad panel next generation sequencing. I would go even further that even early stage patients need biomarker testing. Today we're going to really focus on the metastatic setting. And in patients with non-small cell lung cancer, that is adenocarcinoma, the rates of driver mutations such as EGFR and KRAS and ROS1, which we'll discuss tonight, we see these in upwards of 50% of our patients. Even in squamous histology, which generally does not have driver mutations that are actionable, we see 1 to 2% having an EGFR mutation. So my practice is to do broad panel next generation sequencing in all patients diagnosed with lung cancer. So why don't we get started, and we're going to jump in with targeting EGFR. And with that, I want to turn it to my colleagues, the Oncology Brothers, Dr. Rohit Gosain and Dr. Rahul Gosain, to get us started.
Good evening, everyone, and welcome to this CME event focused on precision medicine in non-small cell lung cancer here at ASCO 2025. I'm Rahul Gosain, as always, here with my brother, Rohit Gosain. Together, we are the Oncology Brothers, practicing community oncologists with hope to bridge the gap between academic research and the real-world challenges we face in community practice.
With most cancer patients getting their treatment in community settings, our goal today is going to be focused on some real-life cases and questions we wrestle with when navigating biomarker testing and targeting therapies in non-small cell lung cancer. Biomarker and NGS testing is in fact the cornerstones of precision medicine in non-small cell lung cancer. In my community practice, I routinely would order NGS on both solid and liquid biopsies at diagnosis, and again, often concurrently. But when that dense NGS report lands on our desk, it can feel like decoding a secret message.
Rohit, let's take this real case in hand. A 62-year-old with metastatic non-small cell adenocarcinoma. Liquid NGS report showed EGFR exon 19 deletion and a co-occurring TP53 mutation. From the panelists, I would love to know Does the variant allele frequency play a role? Should we expect a different response rate based on the allele frequency one might see on the NGS report? What is the prognostic impact of that TP53 co-mutation here? And how does this really guide your treatment, as now we have multiple treatment options, from single agent osimertinib to osimertinib with chemotherapy or amivantamab with lazertinib?
Though these patients are living longer, unfortunately, we still expect this disease to progress. How do you sequence what next? And can you also touch on few potential upcoming treatment options, that is HER3-DXd or Dato-DXd?
So thank you to the Oncology Brothers. So young patient, EGFR mutation, co-mutation in P53, and positive for ctDNA. So I want to turn it to Dr. Zosha Piotrowska to give us a brief evidence review of EGFR targeted therapy, and then we'll have a discussion.
Great, thank you. I think so many really important and clinically relevant questions raised by that case. I think all questions that we all face in our practice. So my goal in the next few slides is really to give you a high-level overview of the kind of first-line treatment options that we have, and then we can delve into some of the questions afterwards. So this is a very busy slide, purposefully so, just to highlight one key important distinction, which is the importance of keeping in mind that classical EGFR mutations, the EGFR exon 19 deletions and exon 21 L858R mutation are really what we're going to be focused on today, but they're distinct from the atypical or uncommon mutations that you see in the middle and the exon 20 insertions, which are treated differently beyond the scope of this discussion. But again, right now we're focused on the classical mutations. For patients with metastatic classical EGFR mutant lung cancer, the FLORA trial established first-line osimertinib monotherapy as the preferred first-line treatment in 2018. OC improved outcomes in terms of progression-free and overall survival over gefitinib and erlotinib, but the median PFS was 19 months, and we all knew that we needed to do better. Now, we have two randomized phase 3 studies which have improved upon that standard of care. The first of these is the FLORA-2 study, which you're all familiar with, but just briefly, this was osimertinib plus platinum pemetrexed chemotherapy as a first-line strategy compared to osimertinib alone. And here we saw an improvement in progression-free survival from 16.7 to 25.5 months. That was the primary endpoint of the study. Overall survival data from the study are not yet mature, but are trending in the right direction. In a second interim analysis presented last year, hazard ratio was 0.75. Of course, adding chemotherapy adds an intravenous infusion regimen and toxicities of chemotherapy, as you can see listed here. We also have, as the Oncology Brothers mentioned, the option of Mariposa. So Mariposa was another randomized phase 3 study looking at a different combination, amivantamab, bispecific antibody targeting EGFR and MET, compared to osimertinib alone. There was also a lazertinib arm in that study. But looking at Ami-Laser versus OC monotherapy, again, we can see an improvement in progression-free survival. That was the primary endpoint of the study, 16.6 versus 23.7 months. This was the primary endpoint of the study, and this was positive. And we also saw at ELCC this year the overall survival data from this study. And this was the first of these studies to show an improvement in overall survival. Hazard ratio here was 0.75 on the final analysis. The median has not been reached in Ami-Laser, but it's projected to be over 1 year. Now, of course, amivantamab lazertinib also adds toxicities. They're different than those we see with FLORA-2, dermatologic toxicities, the risk of venous thromboembolism, the risk of infusion-related reactions, even more frequent visits. So there's pros and cons to each of these regimens. Fortunately, I think that the sponsors of these studies have done a great job of developing prophylactic regimens to help us mitigate these toxicities. We won't go into them in detail, but I will refer you to the Cocoon trial, which showed that dermatologic prophylaxis, including minocycline or doxycycline and prophylactic topical medications, can help decrease dermatologic toxicities. Prophylactic steroids can decrease infusion-related reactions. And then, of course, sub-Q formulation of amivantamab will help there too. And then these patients require prophylactic anticoagulation to mitigate the risk of VTE. So with that, we have these three options. We're going to talk about how to apply them in practice. But before we delve into that, I just wanted to call your attention to a couple of EGFR-related abstracts to keep an eye on, both in the oral abstract session being presented tomorrow morning. One is looking at patients with acquired resistance to osimertinib monotherapy with MET amplification as a resistance mechanism. This was a randomized study looking at savolitinib and osimertinib, so EGFR and MET inhibitor, versus chemo in patients with MET amplification, a study from China. And then in the exon 20 population, we'll see updated data for an EGFR exon 20 TKI, zipalertinib, in patients previously treated with chemo plus or minus amivantamab, presented by my colleague, Dr. Yu. And then maybe we can jump into some of the excellent questions that were raised in the case.
Thank you, Zosha. So I want to go back to the case from Rahul and Rohit. And Jonathan, I'll go to you here. We have 3 FDA-approved regimens. Osimertinib as a single agent. We have osimertinib and chemotherapy. And more recently, we have amivantamab and lazertinib. So this is a younger patient. She's fit. She has an exon 19 deletion, a co-mutation in P53. Let's say no evidence of any brain metastasis. How are you thinking about this patient? What's the discussion like in your practice?
So this is an important and challenging and longer discussion than we've had before. I try to focus on the importance of new options for our patients, new options that are providing more activity. We still discuss osimertinib monotherapy, but talk about the concern about the TP53 mutation in particular. And as a younger patient, we have goals of really longer term survival. So I think this is a case that I would encourage a combination therapy. The choice between FLAURA2 and Mariposa is somewhat challenging, and I think requires longer discussion with the patient about the time in the office, the different toxicities, and but this is a case where I feel comfortable saying combination therapy would be a benefit over OC monotherapy.
Yeah, and Zosha, we heard from Rohit, a lot of these NGS reports have many pages, and are you digging into page 35 where the co-mutations are listed, and how does that guide your practice? And we talk a lot about high-risk features in patients and when to escalate. Are there patients where you're de-escalating?
Yeah, I think it is important to look at these NGS reports, both in terms of, again, the specific types of EGFR mutations, the presence of co-mutations. I think TP53 is the one we look at most, but we probably don't fully understand the impact on all the other kind of co-mutations there are. I think in my practice, I'm really looking for the number of different kind of high-risk features that these patients may have to push me more strongly towards a combination or less, I think together with patient fitness and then importantly, patient preference. So P53 mutations, the presence of L858R, which historically has been, has a poor outcomes with osimertinib, the presence of brain mets, kind of a higher overall disease burden. All of these are factors that might push me more, the baseline ctDNA positivity. On the converse, an older patient, maybe a patient with borderline renal function, not fit for combination therapy. These are things that might push me away. And it's not black and white. I think it really has to do with both those disease factors and the patient factors, and then a discussion with the patient to see what fits best with their goals and values.
Yeah, I couldn't agree more. And we saw data from the 2 combination strategies of osimertinib and chemo, FLAURA2, an improvement in PFS. We don't yet have full overall survival data. And we also heard from you that amivantamab and lazertinib has PFS as well as overall survival benefit. So Dr. Lopez, Gilberto, what is your discussion regarding efficacy versus toxicity? And how are you thinking about managing the toxicities in the clinic?
So it's become extremely interesting. We have gone from an unusual situation in what we do, which is to have one specific standard for nearly a decade. So that's not what we as thoracic oncologists have done. We've debated if we use paclitaxel or docetaxel, cisplatin, carboplatin. So it's unusual that we had one standard for this long. So we now are falling back to where things were, that you have many options for our patients. And I think that that's key, that we do have many options. So it probably will make a bigger difference if you get exposed to all active drugs versus exactly how we do it. But having said that, it is clear that there are patients that have worse prognosis. We all have patients that have been on osimertinib for about a decade. Unfortunately, we do not know who those patients are a priori. We really know them because they've been on it for so long. And now that we do have options in doublets, I think that for most patients, we will be using doublets. We will, of course, for patients who do not have a great performance status or that who by preference would like to truly focus on quality of life and only take a tablet. Those are patients that we might still use osimertinib as a single agent, but today, to me, that's less than 25% of our patients. I would say that 75 to 80 do want the doublets once they hear that you have better overall survival and certainly better progression-free survival. Now, how to choose between chemo plus Osi versus amivantamab plus Lazar, that unfortunately we really don't have a great answer. We do know that for every subgroup that we looked into, you really did better with the doublet versus the single agent. So I think that that is true. Question is, how do you choose? And today, patients actually do come see us with an idea of what they want to try. I've had patients come in and say, look, I've heard that amivantamab causes too much skin toxicity. I like going to the beach. I live in Miami. I do not want to have that side effect. On the other hand, I say, my uncle had horrible chemotherapy toxicity. They do not want to do even carboplatin pemetrexed, so that helps. But I think the important thing is that we need to learn how to manage the toxicity. And we are pretty good with carboplatin and pemetrexed. We use folic acid, we use B12 injections, we use dexamethasone to prevent edema, not necessarily for everybody, but we can discuss that as well. But we really need to learn how to manage amivantamab and with laser, and that truly takes a lot. We do need to make sure that we have the skin, the dermatology regimen, and that we are comfortable with that. And we also have to remember that patients have to get an anticoagulant as well. So we do need to have that discussion with patients. And these are absolutely right. This used to be a 15-minute discussion when we had the Griso alone. And now, of course, it becomes an hour long, and sometimes we don't decide on the first visit. Patients do rely a lot on patient groups as well. I have patients that come to me and say, look, my colleagues or my friends from EGFR resistors or from this group or that group have been doing this, so they suggested that. So it has become a very interesting discussion. I wouldn't quite say we're breast cancer yet, but we're getting there. Yeah.
Yeah, so a complicated discussion and a complicated space. And, let's throw in, a patient now has brain metastasis. Jonathan, how does that change your calculus in this discussion? Are you leaning more for the combinations? We already talked about escalation for most patients, but how do you think about that?
Well, there are those different factors that each provide some concern, and brain metastases are another one, just like liver metastases, TP53 mutation. I think that as they accumulate, I start to push more and more for combination therapy. It is interesting and perhaps unexpected that either chemotherapy or a bispecific antibody has an effect on brain metastases, but we now have 2 trials showing perhaps, just from systemic improvement in therapy, disease control, or from some CNS penetration that was greater than expected, we are improving the outcomes for these patients. And so that would only push me further towards using a combination therapy.
Yes, as our survival continues to improve, we've moved from 3 years to about 5 years in the EGFR mutant space, and we hope to continue to improve upon that. But we're not curing our patients with stage 4 EGFR mutant lung cancer. So Zosha, what are the resistance mechanisms that we're seeing, and what have you seen from the combination data to sort of support how we think about those resistance mechanisms?
Yeah, I think, we're still learning about the resistance mechanisms to these combinations in FLAURA2 and Mariposa. My overall sense is that they're not dramatically different than what we learned about with osimertinib monotherapy. Perhaps a little bit lower rates of on-target EGFR resistance mutations and MET amplifications seen when they looked at plasma in the Mariposa trial. But I think that, the key question for a practicing doctor is, what do we need to look for? What's actually actionable? And the 2 things I would point to that I think we really do need to look for when patients progress on any of these therapies containing a TKI are, one, histologic transformation, which, still is a recurrent resistance mechanism, which has important treatment implications, and as of now can only be detected by tissue biopsy. So, just a plug that I think there's still a role for tissue biopsy here. And the second is MET-mediated resistance, which again is actionable. We're going to see more data. We've seen a number of different MET TKI plus EGFR TKI combinations in these patients. We'll see more data tomorrow. These patients really do benefit and can have durable responses when you add a MET inhibitor, savolitinib, tepotinib, and others to osimertinib. So important to look for, MET amplification by NGS or FISH, but also MET protein overexpression can be seen. So those are the 2 things that I think we particularly have to look for. You can also see EGFR resistance mutations, rarely acquired fusions. Those are uncommon. I think, the ones that are most actionable and really are the ones that are driving me to have the discussion about a biopsy with patients are histologic transformation and MET.
Yeah, I couldn't agree more. So really, to summarize, a complex space, osimertinib has been a standard of care for exon 19 deletion and LA58R, but we now have better strategies, escalation strategies, where people are doing better and potentially living longer, and that is osimertinib and chemotherapy, as well as now amivantamab and lazertinib. So I think you heard from the panel that it is important to discuss these regimens with our patients, but also to discuss the toxicity profile and how do they align with that patient's quality of life. So I got a question in here from one of our colleagues here. They have an adenocarcinoma histology with an EGFR mutation. Gilberto, how are you thinking of that patient? Are you giving, osimertinib plus chemotherapy? What chemotherapy? Are you giving amivantamab and lazertinib? How do you think about that? Adenosquamous probably makes up about 5 to 7% of diagnoses. Remember, oftentimes you need that on a core biopsy or resection. On a small FNA, you'll miss that diagnosis.
So we do have evidence that depending on how much that squamous component is, you actually do have efficacy with pemetrexed. But many of us still feel a little uncomfortable with that approach sometimes, and often we will resort to using taxanes. Of course, we don't have data for taxanes in combination of osimertinib. Is it an extrapolation that you might be willing to do? Probably. I can't remember when was the last time I saw someone with an adenosquamous with EGFR, but I do have a patient who's a firefighter and has a squamous cell with EGFR mutation, and that was clear. She got osimertinib initially, and at progression, we enrolled her in a clinical trial that had an HDAC inhibitor. She did not respond to that, and she's been on full chemo with paclitaxel, bevacizumab, and tislelizumab, and she's actually been responding for 6 years. So it is a very unusual. It's not a regimen that we would even discuss here today anymore, but historically has had a role.
Yeah, so excellent question. So let's move into targeting HER2 mutations as well as HER2 overexpression, a space that has become very complicated with many therapeutic opportunities entering. And with that, I want to turn it again to my colleagues, the Oncology Brothers, to get us started, Dr. Rohit Gosain and Dr. Rahul Gosain.
Rohit, we are facing high patient volume day in, day out in our community practice. And we see everything from lung cancer to breast cancer to GI malignancies. One big advantage ends up being around these bucket approvals. We get comfortable with a lot of these new agents quickly as we're using them in multiple different disease sites. One common example here is HER2 positive disease. But there is a lot of confusion on how to define something that is HER2 positive, as this differs from disease site to disease site. For the panelists, can you define what qualifies as HER2 positive disease? And then can you touch on the data? How effective are our treatment options if it is ERBB2 mutation versus IHC overexpression for HER2?
When talking about HER2 disease, how sensitive is liquid NGS testing for HER2 mutation given tumor heterogeneity? Also, I wanted to mention that HER2 exon 20 insertions is different than EGFR exon 20 insertions on NGS report. There's a lot of excitement around upcoming TKIs in this space. As the community oncologist, what should be on our radar in the near future?
Thank you, Oncology Brothers. So how do we differentiate overexpression from amplification from mutation? So I want to turn to my colleague, Dr. Gilberto Lopes, to give us a brief evidence review of the HER2 targeted therapy.
With pleasure. So HER2 is also in the epidermal growth factor receptor family. So this is actually relatively similar, but in many ways it's a lot more complex. We have had a classic definition of what HER2 positivity is in breast cancer and in gastric cancer, and that definition is now coming into becoming something completely different. In lung cancer, historically over the last 10 years, it has been mutations that matter, but as we will see in the data that I'll show in a couple of seconds, we also are looking into IHC positivity as well as amplification. So we do see in the Venn diagram that we can talk about amplification, and we usually use FISH, but NGS can also tell us what that looks like. We look at mutations, which historically is, again, what we have been using, and we can look at overexpression with IHC. Historically, you need a 3+ positivity for that to be overexpressed. Now with trastuzumab deruxtecan and newer drugs, we're seeing that 2+ and maybe even 1+, we might actually see responses and a clinical benefit. This is Destiny Lung-02 trial. It's the first trial, or one of the important trials that we have seen in this arena. Patients were randomized to receive 2 different doses, 5.4 or 6.4 milligrams per kilogram. Results were relatively similar in terms of progression-free survival, but 5.4 and response rate, but 5.4 was of course better tolerated. And this is something that we have moved, at least in the lung arena, to use this dose. And this again is of HER2 with mutations. We also have in Destiny Lung-01 results that we have seen already for patients that have overexpression. So we see that the results are not as many and not as deep, but we do see responses. Is this better than getting chemo and immunotherapy in the first line? Probably not, but this is certainly something that has activity, and we have used for some of our patients, and we have started to actually test routinely for HER2 through immunohistochemistry as well as FISH in our practice. We also have DESTINY-Lung03, building on that story of HER2 2+ or 3+ in lung cancer, and we see that both 2+ and 3+, we have seen responses in stable disease and median progression-free survivals that are in excess of 8 months. So we do see activity, but of course it is with mutations that we see better responses and longer responses. We have 3 trials. There are the main trials that are ongoing that will give us an answer in terms of comparison with chemotherapy, including pemetrexed and carboplatin, and immunotherapy in first line, DESTINY-Lung04, SOHO-02, and BEAM-Lung2, and these are all for patients with HER2 mutations. Even though the title says third, this is specifically for mutations, and of course we'll have time to discuss that as we move forward.
Thank you, Dr. Lowe. So let's get practical here. Zosha, you have a HER2 exon 20 mutation patient. Remember, this is a mutation. What are you doing in the frontline setting, Zosha?
Yeah, so one important point, and I've seen this come up in practice, it is very confusing, but these are different than exon 20 insertions. And, it's really important to keep those distinct. For a HER2 mutant, exon 20 insertions are the most common here. Right now, I'm still using chemotherapy for these patients, discussing, debating the use of immunotherapy in my own practice. For many of these patients, they're younger, they tend to have no smoking history, so often I'm omitting the pembrolizumab, but you could argue that either way. And currently thinking about trastuzumab deruxtecan in that second line.
So I completely agree.
Trials, of course.
Yeah, for sure. Trials are always a great option. So I completely agree. And Jonathan, a patient here starts carboplatin pemetrexed and then progresses after 7 months. What are you thinking about in the second line? And sure, clinical trials are an option, but let's get our community hats on for a second. What's available for that patient?
So trastuzumab deruxtecan is, I think, an excellent choice for the patient. It is an antibody drug conjugate against HER2, and we do find activity, but obviously in breast cancer, but also in lung cancer. It is meaningful. It can be durable. It is not the easiest of drugs. We do have to look for an interstitial lung disease, fatigue, low blood counts. But the activity is meaningful and can be quite significant for our patients.
Yeah. And interesting, there are a lot of different HER2 inhibitors being developed here. We'll see some data for SOHO2, the Bayer compound 292. We saw data for zongertinib, BI 181. And I think targeted therapies are very quickly entering this space. Gilberto, to end, this is a patient you see in your practice with no driver mutation. They progress on chemotherapy and immunotherapy, and then you identify them to have HER3 or HER2, 3+ overexpression. What are you considering in your practice?
So this is a patient that if we are in a community oncology practice and clinical trials are not an option, trastuzumab deruxtecan is truly the option that we have there. Response rates with T-DM1, with neratinib, with older HER2 therapies, both oral lapatinib, we really didn't see any responses at all. So it is with trastuzumab deruxtecan that this starts becoming an option.
Yeah, excellent discussion. So we're moving on, and we're going to go quick tonight, so get your roller skates on here. We're going to move to targeting MET overexpression and MET exon 14 skip mutations. And again, I want to turn it back to my colleagues, the Oncology Brothers, Dr. Rohit Gosain and Dr. Rahul Gosain.
Days before ASCO and this meeting tonight, we've seen another approval in lung cancer, Teliso-V vedotin, an ADC for MET overexpression. This is different than MET exon 14 mutation. Is this a resistant mechanism, or can this be tested upfront at the time of initial diagnosis? Can the panelists share what is their current workflow for IHC testing to look for c-MET overexpression, and then what data do we have that led to the approval of this drug?
With any new drug, we also need to keep the side effects that come along with these in mind, especially in metastatic settings where the treatment is in fact palliative in nature.
Absolutely.
As we walk through the efficacy data, can you also touch on few common side effects for us to keep in mind and how to manage them?
So exciting approval of Teliso-V in the MET overexpressed 3+ population. I'm going to turn it to my colleague, Dr. Jonathan Goldman, to give us a brief evidence review of MET targeted therapies.
Those were such good questions and really highlight where we are with MET. It is a really multifaceted oncogene functioning as we were discussing with HER2, but I would say even more so. Here we have HER2 mutation, which has been well understood and well targeted now with a couple of our agents. We also have amplification, which we've understood but had trouble targeting over the years. And now we have overexpression. I'll start with overexpression. Teliso-V vedotin, or Teliso-V, was approved just earlier this month. This was an accelerated approval based on the Luminosity trial. We identified patients based on their HER2 overexpression. The biomarker is a little complicated. It's percentage of 3+ cells being 50% or greater is considered high. Intermediate is 25 to 50%. These are all 3+ cells, so a high bar, but it does show you that actually these are quite prevalent. It's always good, I think, to have a little competition here between the different speakers. And so this is probably the most common of these oncogenes that we're going to, or of these oncogenic potentials that we're going to talk about. About 25% of cells will have overexpression. Half of those will be these c-MET high. The patients here that were treated with Teliso-V, pre-treated patients, had about a 35% response rate. Significant improvements over the standard of care options that they would have otherwise. The intermediate group, also probably clinically meaningful, 23%, but perhaps similar to response rate with standard of care. So we'll have to see what a direct randomized trial shows. We see the waterfall plot on the right, really meaningful shrinkage. Interestingly, the duration of response, progression-free survival, was similar if you got a response in the c-MET high and c-MET intermediate group, just over 7 months. But really, I think a meaningful new opportunity for us as we treat our patients. Identifying the patients, though, is the next important step, and really I thought was brought up so well by the ONC Brothers. This is going to be just like HER2 testing, important to be in close contact with our pathologists when we identify new targets. You can test the diagnostic specimen. That would be sort of the easiest way to lay out your options for the future. But we do see that on resistance to first-line therapy, MET overexpression goes up by about 10%. So you could even consider rebiopsy or biopsying at progression and testing that specimen. Because it's immunohistochemistry, it should be a relatively fast turnaround. Very quickly, all of the reference labs have added on MET overexpression testing, so you can ask your reference lab to test for you. Toxicity is important. I have found this to be one of the better tolerated antibody drug conjugates. There is the MET targeting toxicities that we see similar to other MET drugs that we'll get to in a second, peripheral edema and hypoalbuminemia, but generally less than with the TKIs. The two toxicity, or perhaps three toxicities to consider. Peripheral sensory neuropathy is not rare. 30% patients, 7% were grade 3 or higher, as opposed to taxane neurotoxicity, though. I have found it to be reversible, so taking a short break, perhaps lowering the dose, allows the patient to stay on therapy. I do have one patient who's going on now 5 years. We hold many of the therapies, but he continues. He did do dose reduction. We've really had otherwise a continued excellent quality of life. I also wanted to mention ocular toxicity, which is something that usually can be managed by eye drops. And there is with many of these ADCs, interstitial lung disease. Not at a particularly high rate, but something to have on your radar screen when you're looking at scans or checking with patients about symptoms. We're going to quickly talk about the TKIs that we're familiar with. Two drugs, capmatinib and tepotinib, which were approved for MET exon 14 skipping mutations. These were in many ways similar drugs, response rate of about 40%, 45%, progression-free survival of about 6 months. Capmatinib, their data looked a little bit different when you looked at the previously untreated, treatment-naive patients with a response rate closer to 70% and a progression-free survival beyond a year. They're both really important parts of our armamentarium, though.
Thank you, Jonathan. So great discussion on MET. Very exciting to see a lot of, sort of controversy with the ADC. So great to see an ADC approved in the second line setting. So yes, no. Jonathan, are you testing for MET in your practice?
Yes, continued as part of the trial, but yes.
We started 2 weeks ago.
Zosha?
Starting.
So we've been testing for 6 months, and I think it's critically important. A lot of the commercial assays that we're using in community practice are testing. And then for Menexon 14, Gilberto, tepotinib versus capmatinib, any major difference for you?
Does anybody have a coin? So I tend to use capmatinib out of habit more than anything else. We really don't have a lot of, except for the toxicity, we don't have a lot to differentiate them. So it is just still a little bit of a toss-up. We tend to use what we started using, so tepotinib it is for us.
I want to move it to targeting ALK, and I'll turn it over to my colleagues. This is Dr. Rahul Gosain and Rohit Gosain.
Let's shift gears to ALK mutations. What we have is a patient who's 48 years old, metastatic non-small cell lung cancer with bone-only disease. As I mentioned before, I would be ordering liquid and solid NGS concurrently, and that's exactly what I did here. Liquid tissue did come back negative for any actionable mutation. In-house biomarker testing showed high PD-L1 score. My practice ends up being considering chemotherapy alone till solid tissue report is back, and then add immunotherapy if no targeted mutations are available, or if there is one, then I rely on the targeted therapy there. For this patient, solid tissue did reveal ALK-positive disease. For the panelists, a couple of questions here. Starting off with, can you please touch on importance of RNA versus DNA-based NGS testing? And when it comes to ALK mutation, how do you pick your first-line treatment, especially given such impressive CROWN trial data that we saw last year, with significant benefit, but this, of course, comes at cost of side effects?
And when talking about ALK-positive disease, I would love to hear your practice around retesting, and how do you sequence your available ALK inhibitors in a patient at the time of their progressive disease?
Thank you to the Oncology Brothers. So a lot to tackle here. How do we think about the difference between RNA and DNA, and many ALK inhibitors approved in this space? Zosha, please take it away to give us a brief evidence review of ALK-targeted therapies.
Yeah, and we can come back to some of those great questions in this discussion. So very briefly, we have really a wealth of options for patients with ALK-positive lung cancer. On this table here, you can see the different approved ALK inhibitors kind of going by generation, starting with crizotinib, our oldest drug, a number of different second-generation ALK inhibitors, ceritinib, alectinib, brigatinib, and incertinib, and then the third-generation drug lorlatinib. Now, I will note that as we get kind of into the newer generations, these are defined by a few key features: increased on-target potency, broader coverage of ALK resistance mutations, and importantly, really importantly, CNS penetration. And the landscape of the first-line trials in ALK have really relied on crizotinib as the control arm for many of these studies. It's a little bit challenging because, of course, as these studies have gone on, the landscape has evolved, but we have data with alectinib, brigatinib, and lorlatinib, each comparing them to crizotinib, and we're left really with essentially cross-trial comparisons when looking at these data. So just to dive into a few of the key studies here, first we had the ALEX study, which compared first-line alectinib to crizotinib, and it showed clear improvements in efficacy with alectinib in terms of progression-free survival and overall survival, as you can see here. Really we see quite high durability of these responses to alectinib. If you look at the time in months there, you can see that. And we see benefit to alectinib in patients both with and without baseline CNS metastases. Again, alectinib is a CNS penetrant therapy, and patients with baseline brain metastases can certainly benefit from alectinib. I think that's one of the big liabilities of crizotinib as the oldest of these drugs. It has the least CNS penetration. But now, as the Oncology Brothers referred to, really the study that has, I think, gathered the most attention and discussion in our clinical practice recently was the CROWN trial. This was a first-line study for ALK-positive lung cancer that looked at the third-generation ALK inhibitor lorlatinib, again compared to crizotinib here. And we already knew from older 3-year follow-up data that clearly lorlatinib was the winner here. It significantly improved progression-free survival compared to crizotinib. But last year at ASCO, we saw a 5-year follow-up from the study. This was actually a post-hoc analysis analysis that was done because so many patients were still on study. And if you look at the 50% line there, it has not yet been reached at a 5-year follow-up. So 60% of these patients are still on their initial first-line therapy. Really striking numbers here, clearly better than crizotinib And not shown here, but equally impressive were the intracranial efficacy data, really essentially flat curves across the top of the Kaplan-Meier curve with very few CNS progression events in patients treated with lorlatinib. And I think this data really has impacted our practice. But as the Oncology Brothers alluded to, there are differences in safety profiles between these drugs. Here you can see some of the key toxicities of the second generation ALK inhibitors compared to lorlatinib. And I'll just highlight that the main kind of toxicities to be aware of with lorlatinib are cumulative edema, peripheral neuropathy, weight gain, but I think really particularly important for our patients' cognitive effects, which can be a variety of different symptoms, mood disturbances, sometimes a feeling of kind of emotional lability. Patients describe a variety of different things, and they can have an impact on quality of life. You have to manage the dose very carefully. Also, hypercholesterolemia, hypertriglyceridemia, so you have to monitor lipid panels for these patients. And again, remember, these are young patients, often with few other medical problems, who are staying on this therapy for 5 years or longer in many cases. And so the cumulative effects of hyperlipidemia, weight gain, things like that have to be weighed into the discussion of how we select between these agents. For patients who progress on ALK inhibitors, including patients who progress on alectinib and lorlatinib, we have exciting new agents coming down the pipeline. And here I'll just highlight NVL-655, also called neladalkib now. This is a drug that's currently being evaluated in a variety of contexts. This is a busy slide, but what I'll highlight is that this drug has activity in patients treated with any prior ALK inhibitor, including those treated with prior lorlatinib. You can see here response rates between 35 up to 50% if patients have an ALK resistance mutation, suggesting continued ALK dependence. And I think equally importantly, if you look at the toxicity table, this is a fairly well-tolerated drug with relatively few grade 3 or 4 toxicities, although as you can see, you have to keep an eye on the LFTs. And then last point here is this drug is also CNS active. So intracranial responses were seen in lorlatinib naive patients, and then also in a fewer number of patients treated with prior lorlatinib. So there's a trial in progress of the phase 3 Alcazar study looking at neladalkib versus standard of care for first-line treatment. That's available to review here at ASCO, and I think we are all eager to see more data with this and other compounds in development.
Thank you, Zosha. So we heard from Rohit that his patient had DNA-based NGS and did not identify to have any fusion, and then did an RNA-based NGS and was identified to an ALK fusion. So Zosha, why does that happen? And what is the difference between DNA and RNA-based sequencing, and should we be doing both?
Yeah, the short answer is I think we should be doing both. The question is, should we be doing them both at the same time up front, which is actually my practice, or should we be thinking about this as a sequence and really thinking about adding in RNA-based NGS in patients where the DNA doesn't identify something actionable? The key issues with many of the fusion kind of based alterations, including ALK, RET, ROS1, and TRK actually, and even exon 14 skipping, looking at the RNA expression of these provides a higher yield than a DNA-based assay where they can be harder to detect. So in my practice, I think actually just ordering both up front is the most efficient way to do this. But at a minimum, you should think about adding an RNA-based NGS if the DNA doesn't show you something actionable.
Gilberto, you have a lot of experience in this space.
We do. Actually, on Monday, we're going to be presenting 2 studies that are actually extremely interesting because it has been difficult for us to do ctRNA in liquid biopsy. It has been the routine to do RNA testing in tissue for quite some time, and that has been added to NCCN in a number of different guidelines. But we will be showing on Monday 2 studies. One is a randomized trial using ctRNA plus ctDNA versus ctDNA alone. And that's a 150 patient trial. I will not spoil the surprise, but it did show, it's in the abstract, so I'm not spoiling anything. It did show about 20% more fusions were found by adding ctRNA in the liquid biopsy test. And we have a 1,000 patient experience, which is a real world study done in the US and Asia, that we will show also on Monday. This is a rapid oral abstract that we were able to find about 50% more alterations overall and 30% more alterations that were targetable. Yeah. So this is certainly something that we need to discuss more. And we need to look at those platforms that we use for liquid biopsy as well, in addition to tissue, to do those that actually now do RNA. And we can discuss more as we go forward.
Yeah, so it's so important. If you don't identify a mutation on DNA-based NGS, don't give up. You should reflex to RNA-based assays. 15, 20% will have an actionable alteration. So, Jonathan, getting back to the ALK space, you have a young patient, 42, presents to your office with brain metastasis, and she's found to have an ALK fusion. What is your first-line regimen and why?
So we talk about the options. We talk usually about alectinib and lorlatinib, but I do encourage them to choose lorlatinib. I think that it is, the cross-trial comparisons are things that we don't love to do, but here it was really pretty convincing. I think that long-term disease control, including in the brain, younger patients who are starting out not having had brain radiation, not having a long course of previous treatment, I have found tend to do pretty well with lorlatinib. In fact, I used to start at a lower dose, but now I start at 100 milligrams and maybe about half or less end up at some point over years going down to 75. I do spend a long time talking to patients about all the different things that can happen, the emotional lability, some trouble concentrating. Some of these patients, of course, are very high functioning physicians and lawyers and financial managers, and I have found sometimes they have some trouble multitasking. That's been a term that many of them have used. Sometimes use Ritalin actually, and that seems to have helped. I put patients on SSRIs. Many of them have to be on statins. So there's a hypertension control. There's a whole list of adjunctive medications that we have to keep in mind. But the benefit is real, I think, especially starting first line.
Yeah, one quick question from the audience here. Should lorlatinib, with its broad activity against resistance mutations, be reserved for later lines, or should you use it in the earlier on setting? Zosha, are you keeping better drugs for later?
I think that it goes back to the old adage, using our best drugs first. And I think we've seen that over and over again. We know that not all patients make it to next line, to second or third line therapy. And so I think, when we have such potent and active drugs that are providing coverage of these resistance mutations that have better CNS control, clearly the CROWN trial shows us that I think using that drug up front, provides more durable disease control that I think the sequence would provide.
Another great question here. How do next generation ALK inhibitors prevent resistance? So, Jonathan, we know that, all patients with ALK fusion will develop resistance over time, similar to the EGFR space. So how are some of the newer agents, NVL-655, overcoming these resistance mechanisms?
So, we used to spend quite a bit of time looking at the different resistance mutations. Interesting, G1202R was sort of the dreaded one, but a long list. I used to often get testing, look through them, decide if brigatinib or alectinib was going to be the best agent. I still sometimes do make those considerations, but it is also generally true that lorlatinib just has a better, when we look at these heat maps of efficacy against different mutations, there's a lot of green on the lorlatinib map. And so, in fact, I don't always do rebiopsy anymore because usually I end up with the same answer if someone's coming off of alectinib, for example. And hopefully the new drugs will be even better. CNS penetration was a really important part of that. But I think that it's mostly the coverage of the resistance mutations up front, keeping them at a low rate. And it does seem to be different initiating that earlier rather than a development of resistance later.
I couldn't agree more. We're going to get our roller skates back on, focusing here on targeting KRAS, a very, very large space, 30% of patients with non-small cell lung cancer. So let's turn it to our oncology brother colleagues, Dr. Rohit Gosain and Dr. Rahul Gosain. Take it away.
KRAS G12C is one of the most common mutations we see. We have a 70-year-old with KRAS G12C mutated non-small cell lung cancer, which has metastasized to bone, liver, and 2 sub-centimeter brain lesions with good performance status. The treatment options in second line, what we have is sotorasib and adagrasib. But what about frontline treatment options here? Do we anticipate similar response rate with single agent immunotherapy if one has high PD-L1, or chemo with immunotherapy if PD-L1 is less than 50%?
In this patient, we have to worry about intracranial disease. What's the latest data on intracranial activity for available KRAS G12C inhibitors? Outside clinical trials, is there any role of using these KRAS G12C inhibitors upfront?
Great questions on KRAS G12C. Great questions here on CNS penetration. And then how do you move these agents, which are approved, into the later line? So we know that KRAS positive is no longer adequate, right? KRAS makes up probably 30% of our mutations in non-small cell lung cancer, but we need to subset them. So KRAS G12C is probably 40+% of those KRAS alterations. And if you look at that as a whole, it's 10 to 12% of all non-small cell lung cancer. And we know that the different mutations have different responses to specific therapies. So you cannot use a KRAS G12C inhibitor in a patient with a KRAS G12D mutation. So here's the CodeBreak 200 data. This is sotorasib, a KRAS GTPase inhibitor in the second line setting versus docetaxel. And, you know, if you put your sort of academic hat on here, a median progression-free survival of 5.6 months for sotorasib versus 4.5 months for docetaxel, not that exciting. And if you look at overall survival, it was negative. What about in patients with CNS brain metastasis at baseline? This is looking at the progression-free survival. You do see a hazard ratio here of 0.53, so maybe there is a role for these small molecules in this patient population. When you look at patients with pre-treated non-small cell lung cancer with KRAS G12C mutations, response rates are clearly higher, doubling sotorasib over docetaxel, and you do get a median duration of response that's improved. But again, we talked about that overall survival really lacking in this patient population. Moving to adagrasib, a different KRAS G12C inhibitor. When you look at response rates, similar to what we saw with sotorasib, and you do see responses that occur early on. When you look at progression-free survival in the early studies, 6.5 months. But when we looked at the combination again, or adagrasib versus docetaxel in the phase 3 setting, again, the numbers drop quite a bit. We're looking at median progression-free survival for adagrasib at 5.5 months versus docetaxel at 3.8 months. I think, you know, one important thing, again, to note is that the response rate is much higher for these targeted therapies, but the duration of response, again, is somewhat lacking. We're going to see exciting updates here for the phase 2 portion of KRYSTAL-7, which looks at moving adagrasib into the frontline setting with pembrolizumab. And previously, Dr. Yanni and Dr. Garasino have shown us data on PD-L1 high patients, and you see that here response rates are quite high, 59.3% here, previously 69%. But when you look at the PD-L1 low patients, less than 50, the response rates are in that 36% range. Again, duration of response here is impressive in my opinion, but more so in the high PD-L1 expression. So look forward to seeing that full data set. And we also saw data in personal disclosure. I'm involved in this trial of olorasib. This is LY982. This is a therapy combining with immuno in the frontline setting. We're showing data for 43 patients treated in the frontline, showing the toxicity profile, very manageable transaminitis rates, and showing some of the early efficacy data. So look forward to this presentation tomorrow to get the full details. So with that, I want to go towards that question. So Dr. Lopes, I'll start with you. You have a KRAS mutant patient, KRAS G12C patient, who is treated with chemotherapy and immunotherapy in the front line and progresses. You go back to your NGS report up front, and you see that they have a KRAS G12C mutation. What are you using in the second line settings?
So I think that this is a very important point, that in the first line setting, we use chemo and immunotherapy. We are moving away, of course, from using chemo in many different target mutations. KRAS G12C is the one that you want to remember, that we do still use chemo and immunotherapy. Indeed, when we looked at the subset of patients with KRAS G12C in Keynote 42, we actually showed response rates of about 67%. And this is pembro alone. This is not chemo plus pembro. That's why I'm not that impressed with KRYSTAL-7 today. But of course, it is something that we need to look forward to the future. When sotorasib was combined with pembrolizumab in the first line, we had a lot of liver toxicity. We do not seem to see that with adagrasib and with newer KRAS inhibitors. So today, KRAS G12C inhibitors are to be used in the second line after we have had treatment with chemotherapy and immunotherapy. Of course, if you do have somebody that has a PD-L1 of greater than 50%, you could consider using pembrolizumab alone. I would probably still use chemotherapy before I get to the G12C inhibitors.
So Zosha, talk to me a little bit about CNS penetration here. We heard from Rohit, patient with brain metastasis with KRAS G12C. What are your thoughts? How does that drive your decision in the clinic?
I think it's an important point, and I think again here, important to draw the distinction between KRAS and many of the other targeted therapies that we're talking about. We have, I think, Some, although not an abundance of data of CNS activity. I think the most really has been with adagrasib, where we do see, that this drug can have some CNS penetration. With sotorasib, I think that has been shown less robustly, really hasn't been looked at more than it's not CNS active. I just think we need more data there. And again, also really looking forward to seeing CNS data with some of these newer drugs in development. For now, for a patient with brain metastases, I think radiation, unfortunately, still has an important role to play. So these are patients that I'm seeing together with my radiation oncologist. And if the lesions are sizable, or certainly if there's any symptoms, I think radiation is an important component. For a patient with small asymptomatic brain metastases, I have reached for adagrasib in those patients just with the kind of most data there, but I watch these patients very closely. I think it's important to get a short interval brain MRI, again, follow them to make sure that they're headed in the right direction, because I don't think we can, this is not lorlatinib or osimertinib for an EGFR ALK positive cancer, and I think that's really important to keep in mind.
I couldn't agree more. So we're now trying to move these agents into the earlier stage or frontline setting. So Jonathan, what are your fears, your concerns about some of these toxicities when we're now combining these G12C inhibitors with immunotherapy in the frontline setting?
So across many different TKI settings, we found that adding a checkpoint inhibitor was problematic. With EGFR, we saw more interstitial lung disease. With early ALK inhibitors, or actually all the ALK inhibitors, we saw a lot of liver toxicity. And so when we saw some, again, liver toxicity with the KRAS G12C inhibitors, I think there was quickly a recognition that that could be a challenge. I think that in the end, I'm not sure how clear it is that adagrasib and sotorasib are very different there, but sotorasib stopped their program pretty early on and adagrasib pushed forward. There is, I think, we have the appearance that they are tolerable together, but just as Dr. Lopes mentioned, is there going to be an additive benefit? There may not be. I think this first generation of G12C inhibitors was so exciting as a concept. We had thought of KRAS as the undruggable target for so long, and it has very quickly led to a revolution in new options and new study there. But it may be that we're quickly going to move on to new agents once approved.
Yeah, and it's important to note that we focused on KRAS G12C tonight, adagrasib and sotorasib approved in the second line. There are other agents. We mentioned olmarasib. There is an agent, divarasib, and MK-1084. I'm just not remembering the name here. And those are all being looked at in the frontline setting in combination. So exciting space. And we didn't even touch on the other alleles, KRAS G12D or V, or some of the pan-RAS inhibitors. You have to come back to another event to see and hear that. So let's move to targeting some of the less common alterations, and these usually get bucketed into smaller groups because these are more rare mutations. So we're going to tackle RET, ROS1, and NTRK, and I want to turn it back to the oncology brothers here, Dr. Rohit Gosain and Dr. Rahul Gosain, to get us started.
Let's touch on less common mutations, ROS1, RET, and NTRK. These are in fact rare mutations, but with bucket approvals, we are seeing them more often. And of course, thanks to comprehensive NGS testing here. In these mutations, should we prioritize targeted therapies over chemoimmunotherapy for each of these mutations, or rather, in selected few, chemoimmunotherapy would still be a viable option?
So let's move to Dr. Goldman to give us a brief evidence review of RET-targeted therapies with selpercatinib.
RET therapies, I think, it's one of the targets that I'm very excited when I see it. I find that these patients do very well. There are two agents, and I'll be speaking about selpercatinib very briefly, but really an active agent, both systemically and in the CNS. Treatment-naive patients do quite well, and it is generally well tolerated. Excuse me. What we have found is that there can be some challenging new toxicities. We'd see some fluid collections, both pleural effusions and peritoneal effusions, but generally are manageable with dose hold or dose reduction. Some benefit from Lasix, but I have patients on these agents for several years, the high quality of life. This trial comparing selpercatinib to chemo and pembrolizumab showed a meaningful benefit in the progression-free survival. hazard ratio less than 0.5, which I think really solidified its use after initial accelerated approval. Overall survival differences were perhaps not as clear, but I think here you have a case of very well tolerated drug, excellent activity, and perhaps crossover affected some of the OS results. Libretto 432 is a trial that we're looking at. It's basically trying to take an ADAURA approach, but extend it to other targets. We didn't speak much about adjuvant therapy and neoadjuvant therapy, but it is one of the great revolutions in new fields in non-small cell lung cancer. We probably don't have to do this trial in every target, but I think the idea of extending it, showing that it's consistent across some of these targets, using selpercatinib, has all the features of a beneficial adjuvant therapy, well tolerated, CNS penetrant, and highly active. So be looking forward for that. It also allows patients that got definitive radiation, so it will extend the field in that way.
So we'll turn it to
All right,
Lobes to
I'll
talk
take
about
that back.
pralsetinib.
So we, as mentioned, we have two agents. We have selpercatinib and pralsetinib, and we're going to discuss a little bit about that. I had the pleasure of presenting these updated data today with pralsetinib in the metastatic setting as well. What we do see here are the main results. We reached a median overall survival of 44.3 months. You can see the curves on the right side of the slide. What was very interesting that you may not be able to read in the slide is the numbers per region. So if you do remember, when we developed the first generation of EGFR inhibitors, we seemed to get a greater benefit in Asia versus the US. And for these drugs, for pralsetinib in particular, we actually see something that looks like the other way around. We do see better results in the US than we actually saw in Europe and in Asia. And these are some of the results that we showed today at ASCO, and I welcome you guys to take a look at the full poster and the slides. And I will not be able to read it, but the response rates, again, can reach almost 100% when we look at patients that were naive, and more than 60% for patients who were not naive. And when we look at PFS and median survival, we reach a median survival of more than 40 months, actually 60 plus months in the US subset of patients that use this drug. We do not yet have results of the randomized phase 3 trial for pralsetinib as we do for selpercatinib, but they look quite similar, and we do see efficacy that is quite difficult to differentiate. Many of those who participate in one trial or the other, we tend to use the drug that we got to know. One thing that is important to remember is that the toxicity profile can be different. So in selpercatinib, Jonathan already mentioned a few of the side effects. You can also have hypertension, as one of the patients that we had who received selpercatinib and then came to the pralsetinib trial. With pralsetinib, we have anemia, which is not something that we often see with tyrosine kinase inhibitors. And we have other TKI-related toxicity, stomach upset, a little bit of changes in your liver enzymes as well. So those are things to keep in mind. You don't necessarily get toxicity with one if you got the other. In terms of cross efficacy, that's a little harder to answer. We do have case reports of patients responding to pralsetinib after selpercatinib, but the drugs are quite similar. So this is the same generation. It's not, as we speak about crizotinib first and we can getting alectinib or lorlatinib in ALK, but it is something to keep in mind. And there are new RET inhibitors that are under development, and we hope to see those as we move forward.
Yeah, so excellent discussion. So Zosha, in your practice, are selpercatinib and pralsetinib interchangeable, and what are you using?
I would ask for the same coin that you alluded to earlier. I mean, I think these are both great drugs, really efficacious. We didn't touch on, but both have good intracranial activity, really durable responses. I think overall both are well tolerated with some differences in toxicity. So I think they're both very reasonable options. I honestly don't have a strong preference between them.
Yeah, and it's great to have multiple options for patients. I have a patient who's on selpercatinib and had liver function abnormalities, which we see in, 10-15% of patients, and then now on pralsetinib, maintaining response with, better liver function. So it's great to have a lot of options for our patients in practice. So I want to move into ROS1 targeted therapies here. And the ROS1 space, this is an uncommon mutation, 1% to 2% of non-small cell lung cancer. And historically, crizotinib was the leader in this space, right? Remember, we were using crizotinib not just in ROS1, but in ALK and even off-label in MET. More recently, we saw data with entrectinib, very similar median progression-free survival, 19 months, but with a very unique toxicity profile. More recently, the drug repotrectinib, and this is a differentiated therapy in my opinion. It targets G2032R, a common solvent front resistance mutation. It has superior CNS penetration, and here we're seeing response rates in that 80-90% in the frontline setting, as well as post-prior TKI in this space. There's a new agent coming. This is taletrectinib, and this is pooled data from the TRUST-1 and TRUST-2 pivotal cohorts. Again, a very exciting asset in that it definitely has activity against the G2032R. We've seen robust CNS penetration and very, very good response rates. Interestingly, we didn't mention that some of the earlier generation inhibitors like repotrectinib or entrectinib inhibit TRAC, and that can cause some of the neurocognitive side effects, the ataxia, the dizziness. This agent spares TRAC-B and therefore may have a better toxicity profile. So looking forward to hopefully having this drug shortly in the clinic. More recently, we saw data from NVL-520 or zidesamtinib, again, a novel therapeutic with activity against G2032R, phenomenal CNS penetration, and we're seeing patients with robust response rates in later line setting. If you have a G2032R, the response rates are significantly higher, and we also are now enrolling in the frontline setting in this space as well. So exciting space, the ROS1, it's a rare mutation. Gilberto, what are your discussions like in your practice in this setting?
So this may be today where we look at cross-trial comparisons and we make absolute conclusions. Just kidding. We have a huge number of options today, and that is great. We have moved away from using crizotinib for most of it, but we do have several options, and different institutions have adopted different ways of looking into this. Some institutions still prefer entrectinib because they have been using it for a while. Others moved on to repotrectinib, and soon we're going to be moving on even more. So I think that as soon as we have the new drug approved, that may quickly become one of the favorite choices for physicians. And this is mainly because each one of these new drugs has shown a longer median survival in their respective phase 1 / or phase 2 clinical trials. So we do not have comparison between these agents or across these agents overall, but we do have many different options. We also have options for patients that have refractory disease. So that's amazing compared to not having any options 15, 20 years ago.
So Jonathan, you mentioned in the ALK space the lorlatinib and some of the other agents that have TRAC inhibition and that toxicity. What does that look like to you in your practice? Is that something limiting to patients?
It is, and so it's generally, it's described to me as dizziness. That's what I mostly hear. But sometimes people say they feel like they can't get out of bed. Really quite significant.
Actually, I hear I'm quite not myself. I think that may be the complaint that I hear the most, especially with lorlatinib.
Yeah, for me, it's the family members sometimes saying my loved one is not, quite themselves.
Yeah. Oh, I was talking about the TRAC.
Yeah.
But lorlatinib also has a cognitive effect, and people do seem a little out of it, a little bit slower to respond, perhaps. But the TRAC, specifically, I see more of the dizziness. Often requiring dose reduction. I have moved pretty quickly. Initially entrectinib and crizotinib, not a clear PFS benefit, but a CNS improvement with moving to the TRAC inhibitor. But now with repotrectinib and taletrectinib, I think those are meaningful steps forward. So those are what I'm using now.
I think another, kind of practical point about the toxicities that I've run into and learned the hard way is the withdrawal pain that these drugs can have. So this sometimes comes up, you have a patient who may need palliative radiation or SRS, or you want to hold the drug for a short period of time. These drugs can cause significant kind of full body pain that's really neuropathically mediated that can be quite significant if you stop them abruptly. So you have to taper them off of these drugs. And again, I've learned that the hard way for patients. So I think an important, factor to keep in mind with these drugs that have TRAC activity.
Yeah, so those are tough clinical questions.
And there's one more toxicity that I also learned the hard way. It is osteoporosis. So you actually see fractures on occasion on patients on NTRK inhibitors.
Yeah, great point. So Zosha, tough case. You have a patient on repotrectinib. They have a robust clinical response, but they're not feeling great, particularly with the dizziness. Taletrectinib is approved. NVL-520, zidesamtinib is approved. Any role to transition patients onto a therapy that may prevent inhibition of TRAC?
Yeah, well, I think, we've been fortunate to have a little bit of experience with the zidesamtinib in particular. And I think one unique factor of that drug has also been that it was developed to spare TRK and to minimize these TRK toxicities. So I think certainly that would be, an appealing aspect of that. And I think similarly that we've also seen that with taletrectinib, a little bit less of the TRK-mediated toxicities. So I think that while these drugs are similar in a lot of ways, there can be these important nuances in the side effect differences. And in those situations, I certainly think it is reasonable to try transitioning. And sometimes patients can do much better on a different agent. There can be hesitation on the part of patients. They're really attached to these drugs. But I think if you explain to them that there are other efficacious options that may have a better safety profile given their particular experience, I think that can be a very effective way to go.
Yeah, excellent points. And we're going to turn back to you, Zosha, to one of the rare mutations here, this NTRK fusion. So take it away.
All right, so we'll be brief here because these are mutations that are really very rare, or I should say fusions. One important point here is very commonly, I would say, we see NTRK mutations on NGS reports. Those are not actionable. Here, we're really looking for NTRK fusions to think about treatment. So again, important to keep that distinction in mind. But if you find an NTRK fusion in your patient, it's about 0.2% of lung cancer patients. So some of my colleagues have joked, if you find one in your career, perhaps you can retire. But before you retire, you do have some options to treat the patient. Approvals of larotrectinib, entrectinib, and repotrectinib here. And what I'll highlight here is, these are very, very active drugs for NTRK fusion positive cancers, not just lung cancers, but really across tumor types. But what's also really impressive is if you look across the Kaplan-Meier curves along the bottom, these are extremely durable responses to these drugs. If you look at the DOR, the PFS here, PFS with larotrectinib and NTRK fusion positive cancers is 33 months. If you look at that swimmers plot, we are looking at many years of that patients are staying on treatment. So, high response rates, but also really durable responses. I think the similar can be said about entrectinib. This is a drug that, again, you can use both in ROS1 and in NTRK fusion positive cancers. And if you look at the median PFS here, between 20 and 30 months, depending on the patient population here. With this, many of these cohorts are relatively small numbers of patients, just practically because these are not so common. But I think we all have good confidence in using either larotrectinib or entrectinib. And now we also have data from the Trident-1 trial for repotrectinib for these patients. So cohorts 5 and 6 here looked at NTRK fusion positive solid tumors. And you can see in the table here, specifically focusing on NTRK fusion positive non-small cell lung cancers with repotrectinib and TKI naive patients, a response rate of 62%. In patients who were TRK TKI pretreated, so had received larotrectinib or entrectinib, still a respectable response rate of 43%. Here, and we don't have the medians here, but if you look at median PFS, 12-month landmark PFS here, 64% with the treatment-naive cohort, 23%, so maybe a little bit less durable in the TKI pretreated patients. But once again, these are quite impressive waterfall plots for these patients. So I think probably, quite a few options for a relatively rare population, but really critical to find these patients because they can do very, very well if you get them on the right therapy.
Great discussion. Again, that point of RNA being so important here. If you miss it on DNA, you can identify some of these mutations or fusions, I should say, on RNA-based assays. So, Jonathan, your standard of care in NTRK fusion, I have an N of 1 in my experience, so I'll turn it to you.
I don't have a standard.
Yeah, and I'm still in practice, haven't retired yet. Gilberto, what are you doing here?
We use them interchangeably, and I have an N of 5.
Wow, cool. That's impressive.
We get patients sent from the community. Yeah,
sure. And Zosha?
Also, not a lot of experience, but I think they're all good options. And we have to learn from our, thankfully these are drugs that we're using for other targets, so the toxicities are something we're going to be comfortable managing from our experiences with other patients.
Yeah, and my N of 1 treated with larotrectinib was a therapy that I had in sort of clinical experience with on trial, and patient doing very well.
Yeah.
So let's turn to BRAF, actually a space that I think has been undervalued and a space where we haven't really had much change, and we're going to see very exciting data. Jonathan, take it away to talk about BRAF targeted therapies.
So BRAF, this is one of the places like HER2 and breast cancer where we were really able to piggyback on another tumor type. So melanoma, where half the patients have BRAF mutations, V600E, that translated, although much more rare, to a novel therapy that entered the space very quickly. The dabrafenib and trametinib trials showed that efficacy was meaningful. Progression-free survival of almost a year, overall survival of greater than 2 years, the response rates that were useful for our patients, and I think it often was approved to be used as a first-line therapy and was chosen by many patients over chemotherapy. I think there remains a question of how these patients may also do well with chemo and immunotherapy, but I often do start with the targeted therapy. We participated in the trial of encorafenib and binimetinib. Just like in melanoma, this came on as a next generation approach of a RAS inhibitor and MEK inhibitor. And the combination, while not compared directly, does seem to be perhaps more effective. Response rate 75% in the treatment-naive patients, and particularly durable. We have now just put into, it's in press, but a follow-up publication updating that data. In the previously treated, 46% response rate. Progression-free survival, extending beyond not reached at 34 months in the treatment-naive patients, and still reasonably good among the previously treated patients. Toxicities, which I'll just talk about toxicities really quickly, are important for these drugs. You can get some fever, you can get just some stomach upset is quite common, diarrhea. One of the ones that I think can surprise you is development of skin neoplasia, multifocal squamous metaplasia or anaplasia, and occasionally carcinoma, squamous cell skin carcinoma. Usually manageable, but important to tell your patients about ahead of time.
Yeah, so an interesting space, a space where, we're seeing some differentiation, particularly for encorafenib and binimetinib being better tolerated and maybe having better progression-free survival. These are both single-arm studies. So Zosha, how do you decide? Do we need a head-to-head comparison here? What are you doing in your practice?
Yeah, I think that, both of these are very, very active. I've been really impressed with encorafenib, binimetinib data. I think also a distinguishing factor in terms of toxicities has been that the rates of pyrexia are a little bit lower with enco-bini than they are with dabrafenib, trametinib. And in my experience, that can be pretty tough with dabrafenib, trametinib. It's certainly a very active combination, but sometimes these patients can have LFT issues, fevers that can, impact quality of life. So for those reasons, my recent BRAF patients, I've been pleasantly I have had a good experience with encorafenib, binimetinib. Still important to, monitor these patients closely for toxicities, but I think, both are good options.
Yes, we still see low-grade fevers with enco-bini, but significantly lower than dabrafenib and trametinib. So we're going to end here with NRG-targeted therapies, and I want to turn it again to Dr. Lopes to really run through this very rare fusion.
So when you guys thought that we had run out of targets for which we have approved drugs, here comes out of left field NRG. Does anybody know what NRG even stands for? So it stands for neuroregulin 1. Of course, you can cheat and take a look at this slide. And this is extremely interesting because it is also in the EGFR family. So it is a receptor that will actually interfere. And that's why we have a drug. You might ask me, why is it that we have a bispecific HER2/HER3 drug that actually works in an NRG target? And this is the reason why. So when that ligand binds to that fusion protein is going to present the ligand to the HER3 molecule, and that's when it's going to heterodimerize with HER2 and then activate everything that you have in that cascade within the cell. So that is how this works. Extremely unusual compared to everything else that we do, but it is in the same EGFR family, and that's why all of this makes sense, and that's why we use a HER2/HER3 bispecific monoclonal antibody against NRG. And the main reason why you need to know is because we now have a drug approved. How common is it? So it's extremely not common. We see it in about 1 out of 300 patients. In our practice, we have one patient that has started, one patient of my colleague, Dr. Rodriguez Estela, and we have that patient on zenocutuzumab. You get an award if you can pronounce this correctly and quickly within 3 seconds. But this is the importance of this. It is also positive in pancreatic cancer. So those of you that do general oncology practice, you have to remember. And I would say it probably works if you have NRG fusions in any solid tumors, although the current approval is specifically for non-small cell lung cancer, 1 out of 333 patients or more. And pancreatic cancer, I have no clue how common this is in pancreatic cancer, but we can ask my colleagues. And this is what we see. That's the reason why it got approved. We see response rates. We see a median duration of response of about 14 months. And this is certainly interesting. It's a new target. We see response rate of almost 40%, so it's clearly clinically relevant. Toxicity has usually been grade 1 or 2 in severity. Diarrhea, that has to do with the mechanism of action being an EGFR family drug as well. Infusion-related reactions can happen. Fatigue, as with a lot of new drugs that we have seen. There were no grade 5 treatment-related adverse events, and there were no treatment-related discontinuations. So it seems to be relatively well tolerated compared to other new agents.
Thank you, Gilberto. Just because we're running out of time and I want to spend the last 10 minutes answering questions, briefly, LUNGevity Biomarker testing resource, which you saw earlier on the video, so critical. Please visit the website. And we are doing a lot of work on this 14-day rule. A lot of people talk about this in clinical practice. It may delay NGS, a lot of work on the Hill and trying to improve this. And I want to spend some time tackling the questions. We have over 50 or 60 questions here. Wow. So I'm going to select some of the best ones. So a lot of questions on EGFR and toxicity of regimens and how do we manage them? So how manageable is AMI-LAZ in the community? Can you give me guidance on effectively managing the acneiform rash in patients with AMI and LAZ? So I'm going to take, this question. I see a lot of patients, treated a lot of patients with amivantamab. This is a significant toxicity, the cutaneous toxicity, but it is a manageable toxicity, right? If you think about the data for amivantamab and lazertinib, there's an overall survival benefit for this patient population. So in my discussions with patients, I'm explaining to them that we can manage and mitigate these skin toxicities. So how do we do that? We heard from Zosha about the cocoon regimen, so prophylactic doxycycline, chlorhexidine rinses to help prevent the paronychia, as well as topical containing emollients or creams that have ceramides. And we don't all live in Miami, but if you do, to really stay out of the sun or to wear sun protection is critical. And I found in my practice, I've been using these as prophylactic measures for the last 4 or 5 years, a significant improvement in patient outcomes. And we saw that in Cocoon. Important to note that in the actual trial of Mariposa, we did not use these measures, right? So maybe the data could have been even better for patients. Zosha, some questions on IRR, infusion-related reaction. Walk me through, what do you do in your practice to prevent it?
Yeah, so, similar to the Cocoon prophylactic regimen for dermatologic toxicities, the Skipper trial looked at a variety of different prophylaxis regimens to prevent infusion-related reactions, and they found that pre-medication with dexamethasone, and Josh, you're going to have to help me remember the dose.
8 milligrams twice a day.
Twice a day for 2 days before the infusion.
And pretty cool story, briefly, when we studied it in exon 20 in combination with chemo, remember we give, dexamethasone prior, and that's what led to that arm of the SKIP IRR study. So exciting to see that we do reduce the rate of the IRR. But when you see an IRR, what do you do?
So, what I tell patients is almost all of them are going to have an infusion-related reaction. So one is, I think, patient education and equally important, nursing education for your nurses who are actually administering these therapies. We tend to, so they occur in the majority of patients in, with the first infusion. Often we will stop on that first day, once the infusion-related reaction happens. You can start and re-challenge at a slower rate, but I found that often, they kind of continue. But if you stop on that first day and have them come back on the second day, the vast majority of patients then do well thereafter. I think another key point to keep in mind is that if you are taking longer breaks, and again, I don't know if you have a number in mind for how long of a break for toxicities that you're holding amivantamab, say you've been holding for, 4 or 6 weeks, and you're restarting, I think you have to be mindful. I don't know how long you wait before you...
Yeah, we share a lot of patients, and I call you, you call me, but it's really 6 weeks, in my opinion, that if I hold for more than 6 weeks, I want to, then split the dose again. And a lot of people ask me about sort of what happens if you hold the medicine or dose reduce? Does it affect the outcome or efficacy? And we actually have data from Mariposa that, in patients on 4 months or longer, when we look at those holds, the actual PFS in those who held versus those who didn't held are the same. And that's actually really important to think about. It's important to hold medicine and reduce medicine when patients are having toxicities. So a question here about flora too, and Gilberto, I'll take this to you. Do you stop the chemotherapy at the sign of toxicity? And it's a broad question, but what are you doing in your practice and continue the osimertinib alone?
So we, of course, stop carboplatin usually after 4 cycles, and we continue pemetrexed, and it depends on the toxicity. Not that different from what we do with pemetrexed pembro in the maintenance for patients without EGFR mutation. So we tend to continue as long as patients do not have toxicity. Edema starts becoming an issue for a number of patients, so that may be a reason why we would drop the pemetrexed, but often patient preference as well. Once you've been on a drug for 18, 24 months, often patients will ask, can we stop? And I say, sure.
Yeah, I completely agree. And I think there's a difference between stopping at 8 months, 9 months. That was the median on the trial versus stopping after 4 cycles. That's not how the trial was performed. And I think if you're going to do FLORA-2, give the patient the correct regimen for the optimal benefit. So any other last comments on toxicity? A lot of questions here about both of the regimens. Jonathan, any comments on sort of?
I think it's really close communication with amivantamab being we're careful about skin prophylaxis, toxicity prophylaxis, remembering our days of using drugs like afatinib. That we're starting doxycycline up front. We're talking about sunscreen and being in close contact, not being too afraid to take a dose hold, as you said. Topical steroid also, I think, and occasionally, rarely, oral steroids can be very useful. The chemotherapy, I think, many of us have gotten very comfortable with managing chemotherapy, so that has a utility there. I have some patients, not many, but that end up getting growth factor support. I also really do try to keep the pemetrexed going. My long-term patients who are now going on 4 or 5 years, one ran a marathon not that long ago, they're the people that stayed on pemetrexed, and I'm sure there's some selection bias there, of course. But I do like to keep the pemetrexed wand.
And just to highlight, the VTE prophylaxis, I think is also important to keep in mind if you're using Mariposa. And so, it adds up to quite a few things that you have to, educate the patient about. But I think that, for the right patient with the survival benefit, it's certainly a very, doable regimen and one that patients can partner with you to administer the combination successfully.
Yeah, I completely agree. And I think as oncologists, we have to discuss these regimens with our patients. We have to be comfortable with the toxicity profiles, and we really have to guide patients to allow them to select what's the best for them, but not discussing them with patients and clicking that sort of easy button for our patients may not always be the right option. So a lot of questions. Let's move to HER2 here.
I would add one more thing on amivantamab. We have become a little bit more aggressive at using oral retinoids. You do need to register. There's a REMS program just because of the toxicity that you can have if you have a pregnant patient. Patients on amivantamab and lazertinib should not get pregnant regardless. So it's not like the toxicity. The toxicity from oral retinoids is pretty much dry mouth, dry skin, and so on and so forth. Prophylaxis with topical does not work. It was tried in the days we were developing cetuximab and panitumumab, but oral retinoids actually do work. You often do that together at the time you stop drugs, but we have been a little bit more aggressive starting at grade 2 for patients that really do not want to stop or reduce dose. So that's something to work with your dermatologists in your community. It is certainly something that you can try as well.
So a lot of questions here on RNA versus DNA. Is RNA more label? And
yes, it is.
How often are you, reflexing to RNA-based assays? So, Gilberto, I'll go to you here on this one.
So we are using a platform that actually has a reagent that when you put that in the tube, and it's just one tube, you actually get the RNA to be stable for 72 hours, which is enough to ship it to Palo Alto. And that is what we have been doing for the last couple of years. We led a trial called Liquick, and that trial is what we're going to be presenting on Monday. And we have been using that platform for a couple of years because of that trial. But of course, you could use any of the platforms that do use RNA in liquid biopsy. And a number of the commercially available platforms are starting to do it or already do it. So I would talk to your colleagues on the platforms that you use to see if they do use RNA. If they don't, let me know, and I can get you guys to someone who does.
Yeah, so last question as we're running out of time, and again, such a great discussion. Zosha, to you, should the newer ROS1 inhibitors be used as first-line therapy, or would you again save them in your back pocket for later on post-chemotherapy?
I think in general, again, I think the newer drugs tend to be better in a lot of different ways, often, not always, but often better safety, better CNS activity. And so, yes, I think that, we have seen over and over again that generally we are moving towards using them frontline. I think more and more in ROS1, rarely are we using crizotinib anymore, even though it's still an option. I think we are leaning towards entrectinib, repotrectinib. So, I think best drugs first is always the mantra.
I couldn't agree better. And a lot of times our patients don't make it to the second line. So using our therapies up front that are the best are the most important. And this was a tour de force of all the targeted alterations in non-small cell lung cancer. So with that, I want to thank my colleagues here on the stage. I want to thank PeerView and our sponsors, as well as the Oncology Brothers. And have a great evening and enjoy the rest of ASCO 2025.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partners, LUNGevity Foundation and the ONC Brothers. This activity is supported by independent educational grants from AbbVie, AstraZeneca, Johnson & Johnson, Lilly, Nuvalent, Nuvation Bio, and Rigel Pharmaceuticals Incorporated. To access all materials for this activity, visit peerview.com/ZEV860.